Go.
Hello. Let me introduce this video because after this introduction, it will not be me speaking. So, welcome to season 2 of the Podiatry Detectives and the second episode, which we have finally had a chance to do because a certain colleague of mine is super busy, which is good. I'm glad he is very busy, unlike myself. So, Mr. Tosif, how are you, sir?
I'm not too bad. I'm not too bad at all. This is, as you can actually see, my background has actually changed. This is my first video in our new premises.
I hear rumors that you have taken all the patients from Birmingham and they are all flooding to your clinic and everybody else is being bankrupt because of you. So
I was just about to say I wish, but I don't think I'm going to wish for that. No, it's been good. Slowly things are picking up.
That's good.
Presence on the high street. I've started to get patients from the signboard. I think the count is 3 since the board went up. So that's around 2 weeks.
It is an awesome location. If you are in Birmingham or in the West Midlands and you do have foot or leg pain, this is an awesome location to visit. And Tosif is even better than me, and that's saying something. So I would highly recommend you go and see.
You are the guru of it, you know.
Hardly. Don't say that. I've got so many haters after me that would be the worst thing. Today we are doing a presentation on what, Mr. Tosif?
We can basically focus on inflammatory arthritis. So the focus is going to be predominantly on rheumatoid, psoriatic, a bit of gout, and this and that. It's a very wordy sort of presentation. Less of pictures. I wish I would have added more pictures and had a bit more graphic to it, but I haven't. But it's going to be an awesome.
I'm sure you're doing yourself a disservice. I'm sure it will be awesome. I know very little about this subject, so I am going to be listening and learning from yourself. Is there anything else to say? No, let's start the presentation.
Okay, let's share the screen. Right, I've titled the presentation as rheumatoid arthritis because that's one of the main things which we're going to be talking about as a condition, as the treatments when we're going to go through it. So that's why I've titled it as rheumatoid arthritis. Why is my keyboard not working? Yeah. So, rheumatoid arthritis then, Abid. So, do you see many patients with rheumatoid arthritis at all in your private practice? Or?
It's not my kind of demographic. I don't see many of these. Very few RA patients.
I think privately, yes, I have started seeing more and more, but it's not the, a lot of rheumatoid patients are very well looked after in the National Health Service, that they don't really feel the need to basically come out. At the moment, I'm seeing more and more because the coronavirus means that people can't access the NHS podiatry services, so I'm seeing more and more. So rheumatoid arthritis, so it's a chronic syndrome characterized by non-specific, usually symmetric inflammation in the peripheral joint, potentially resulting in progressive destruction of articular and periarticular structure. So very textbook sort of definition. What it generally means is that it's a condition, autoimmune condition, which affects not only your joints, but your connective tissue as well. So anything which includes synovium and stuff like that, it can get affected. Connective tissues can get affected by rheumatoid arthritis. Causes, like lots of other medical conditions, we don't really know the cause of etiology. There is genetic susceptibility and environmental factors which come into play. If you do have a parent or a grandparent who has had rheumatoid arthritis, you have slightly more increased risk of picking up the arthritis. There is some autoimmune focus, HLA-DR4 identified in 60 to 80% of the patients. So yes, there are factors which can predispose you to getting a rheumatoid arthritis more than other people. It's more common in ladies as compared to the men. 1% of population is affected as a whole, so it's a massive, massive deal. 6% of the male over 75 years old get affected, and 16% of the female lesser than 75 or greater than 75. Abid, so what do you think that, now I never get that thing, but is it lesser than 75 or greater than 75?
It's greater, more than 75 years of age, so it predominantly affects females.
Lesser than
the ratio is 3 to 1.
Mm-hmm.
It's a surprising. I've seen so many gentlemen with it.
Yeah, so when you're in clinical practice, as I've done rheumatology for a good while, yeah, I can say that in clinical practice, I've seen that ratio coming in through. One thing which I didn't do is a little introduction about myself and the rheumatoid arthritis, I think we should have done at the start of the presentation, is that, yeah, I worked in the National Health as a rheumatology specialist lead in Buckinghamshire for a short while, and then before that I was a specialist rheumatology podiatrist for a good while for Sandwell. So I had a special interest in rheumatoid arthritis and patient presenting with conditions associated with that. I always thought that can any podiatrist do rheumatology? Yes, they can, but I think they need a little bit more appreciation of the condition itself, the medication and the understanding of the medication, and a slight lateral view on management of these patients, which makes you a little bit better than when somebody's looking at these conditions purely from a musculoskeletal point of view. That's the difference between looking at it from a rheumatology specialist podiatrist point of view and then somebody who's dealing with MSK. Again, the peak incidence is 35 to 55 females, predominantly 40 to 60 male. I actually had a recent win with that, and I think, again, given my experience with the patient with these sort of condition, helped me to get this win where I've got a patient who I've been seeing for last 8 years in private practice for routine care, husband and wife that I actually see them. He had some joint pains and we were looking at it, and he's been going to the GP, and it's a long-winded process. People aren't really figuring out that what's going on, and things are being delayed. I kept on kind of looking at their hands and their feet, and I suspected that there is something untoward and he needed to have some blood tests. So I forced him. I wrote a letter to the GP, which the GP disregarded it. Then I advised them to go private, and they went private. They had some, they saw a rheumatologist, and he was diagnosed with rheumatoid arthritis. Now, in order to prevent the deformities and in order to prevent the serious complications in your feet, NICE guidelines recommend that they need to be on DMARD'S from in 3 months, as soon as possible, basically.
It's DMARD'S.
DMARD'S is the medication, disease-modifying anti-rheumatic drugs, basically.
Okay.
So luckily, we managed to get him on DMARD'S as quick as we could, but it would have been dealt, it would have been had a better outcome. Hence, the GP would have acted a bit more a bit more quickly.
Do you know, this is a whole other debate about how GPs view podiatrists in general. I think this is another video altogether, a lot more controversial one, about other health professions and how well we have these multidisciplinary teams and how well they can work as a team. But well done, well done.
Well, it feels great when you can help your patients. It's not a condition which you want to ignore, especially for the long period of time. So yeah, we had great results following that. He actually went on to DMARD'S and he recovered quite quickly. Well, recovered mean he managed to contain his condition very quickly. Clinical features, onset acute or insidious, so they can actually have acute sort of onset or an insidious onset. Insidious onset, which is slowly coming into existence, has worse outcomes. So you can generally see pain, you can see swelling around the joint and synovium, joint stiffness, loss of joint function, so the amount of range of movement and the quality of movement gets affected, loss of function, and you can see deformities appearing. Usually with rheumatoid arthritis, the first thing to get affected is feet and hands, basically. So you can generally tend to see the deformities in the lesser toe deformities and the deviation of the fingers and hand deformities tend to come in, start setting in place. Muscle wasting is another one, which tend to happen as a result of having the rheumatoid arthritis. Extra-articular disease. So rheumatoid arthritis doesn't just only affect the joints; it affects the extra-articular nodules. So you can actually see little bumps and lumps appearing on around the joints, around the feet. A lot of the nodules, the classic sort of signs of nodules, come underneath the MTPJ. Let me just quickly grab my foot. So MTPJ is right underneath the ball of your foot. A lot of the nodules generally tend to develop there. Vasculitis, so the inflammation of the vessels, that is arteries and other vessels. Anemia is another one which can get affected. Neuropathy. Now, I don't know, have you seen anybody with neuropathy due to rheumatoid arthritis?
Yeah.
Yeah, so the neuropathy is a classic one that a lot of the time we generally tend to miss. We think, right, yeah, they're fine, and then they can actually develop neuropathic changes in their feet. Your eyes can be affected, your kidneys, liver, heart, and all of the other things. And all these things can actually get affected with the rheumatoid arthritis. Increased risk of infection, usually because it's an autoimmune disease. A lot of the drugs that they will be taking is going to be heavy drugs to suppress the immune system, hence why the risk of infection increases. Anything you'd like to add, Abid?
No.
So investigation-wise, so in order to diagnose rheumatoid arthritis, you need to do the blood test, and what they're looking out for is the RA factor. They're looking for anti-CCP in the body, anti-cyclic. I can't pronounce these words, so I'm going to stick with anti-CCP. ESR is erythrocyte sedimentation rate, so the inflammation rate, CRPs. So generally what they tend to do is they tend to look for all these things and collectively come up with a decision from the clinical examination and the blood test examination to diagnose the rheumatoid arthritis.
Okay.
And synovial fluid analysis as well. So these are the investigatory sort of tests they carry out.
So I sent quite a few patients off a blood test. I sent off 2 last week. ESR and CRP levels and like urea levels are something I look at. And then obviously I'm looking, especially if they're South Asian or Afro-Caribbean, I'm looking at vitamin D levels and B12 levels and stuff like that. But these ESR and CRP levels are a good indicator of inflammation anywhere.
Absolutely.
But then if you combine that with your clinical judgment, you can come to a diagnosis quite quickly, actually. Okay.
Usually it's very well studied rheumatoid arthritis, so yeah, they can do a very good job of, a rheumatologist can do a very good job of diagnosing the arthritis. Ongoing monitoring. So once you have been diagnosed with rheumatoid arthritis, you need a regular ongoing monitoring. That is not just from the foot specific, all the way to all the other parts of the body, as rheumatoid arthritis affects pretty much the whole body. So what they do is they do full blood count to assess the anemia. That's done regularly. For some people it's every 3 months. Some people who are managing it really well, it can be a little bit longer. For some people it's a little bit more earlier. Kidney function test is the key one again, because the drugs that you use can affect the kidney and the kidney function. So that test helps to identify if there is a kidney function which is getting affected, the drugs need to be monitored and perhaps altered. Liver function test, it's again the same thing, that because of the drug toxicity and the allergy, people can be on methotrexate, which is a drug for a very, very long period of time, which is a very well tolerated drug basically in the DMARD family, but it still needs to be monitored. And there are, I've seen people at a point when they need to come off it because their liver function test is started to basically alter. Clinical examination, so there are lots of clinical examination one can actually do, but the one which are recognized are GALs and REMS. So usually a clinician generally tend to look at patients' gait, arms, legs, spine, and just a general sort of examination where you keep an eye on all these things. REMS is more regional, so if somebody, for example, comes in with one particular joint, saying that they've got a pain in their ankle, so that's more regional examination. So a lot of us in podiatry, we perform more like regional examination, checking for range of movement, checking for loss of function, checking for quality of movement, the deformities and stuff like that, and that's what you're assessing. Now, a drug therapy, is there an echo in there in the sound?
No, I can hear it.
Okay. So drug therapy is it's very important. It made me laugh because having worked in Sandwell, we have a large Asian population in Sandwell, and I have heard many stories from people who suffer with these sort of illnesses, and then they have these beliefs, then they have like anecdotal stories from other people and other people who kind of suffered, or from back in India and Pakistan, yeah, people have tried to basically cure this problem from different angles, from using the
Haldi.
Haldi
So, you know, yesterday I had a South Asian patient in, and I asked her, I go, how's your medication going for your blood pressure? She goes, I've stopped. Well, she said, I've stopped putter, but she goes, I've stopped. And I go, why have you stopped? She goes, I've been told that I should eat like beetroot and that'll stop my blood pressure going up. And I just did this. I said, you've been told you should eat beetroot. Yeah, so yeah, the cultural and psychosocial behaviors of certain cultural groups is really important when you're dealing with any kind of systemic pathology. But
I must stress that very strongly that if you have been diagnosed with rheumatoid arthritis, the best chance of you preventing deformities and the best chances of you looking after your rheumatoid arthritis and maintaining that functional ability for a longer period of time is to be on the drug and be regularly monitored by your rheumatologist and their team, and following their advice, not to go into these anecdotal treatments.
Absolutely. Although like a turmeric is good for a lot of things, it's not great for this. I've currently got a patient who's got like psoriatic arthritis, who's taking something experimental that his rheumatologist has given him, which is completely new on the market. It's quite interesting, but it's a conversation we should have at some time.
Mm-hmm. So looking at drug therapy, there are newly diagnosed active rheumatoid arthritis. Within first 3 months, they should be on methotrexate plus at least one other DMARD. So now the pyramid for the rheumatoid arthritis management used to be back in a couple of decades ago. It used to be starting with analgesic, and if that didn't work, then progressing it to anti-inflammatories and progressing it to the DMARD'S and then the biologics and stuff like that. But that's actually changed all on its head. So they start more aggressively now. And what I've seen in the clinical practice with that is that with the patients who have been diagnosed with rheumatoid arthritis in the last couple of decades, tend to have much lesser deformities in their feet and much better management of their rheumatoid arthritis, because what happens is that initially, if you don't treat the condition aggressively, once it sets in and the deformities have actually happened, then it's very difficult to go back from there. So drug therapy is a very important one, and it's a very important one in terms of getting it right early and getting in there early. So usually, as I said, methotrexate plus at least one other DMARD for the short term is what's actually recommended. And then they generally tend to monitor their CRP levels and DAS28 to adjust the dosage. I think I've got a little thing on DAS28 a little bit later on, where we can explain what DAS28 is. So if DAS28 is less than 5.1, confirmed on at least 2 occasions, 1 month apart, then greater than 5.1, I mean, TNF inhibitors plus methotrexate. The TNF inhibitors, I'm not going to go into too much detail about the medication. They're listed there, infliximab and all the other. Again, I hate pronouncing the names of the medication because I always pronounce them wrong. So the key thing with regards to the drug therapy is that getting it in there early, regular monitoring to get the dosage right. Once the dosage is right and the condition is under control, then maintaining that. And again, the couple of departments that I've actually worked with and I have met and worked with lots of other rheumatology departments across in England, and it's a very well looked after department, and the patients get a really good care in the NHS with that. DMARD'S, again, in terms of the medications, we talked about disease-modifying anti-rheumatic drugs. So there are several of them. Methotrexate is one of the most common drug which is used for that, and it's very well tolerated as well. Sulfasalazine, leflunomide, hydroxychloroquine is another good one which is prescribed quite frequently. Cyclosporin, some of the names of these DMARDs. Now, biologics is the next stage to the drug management. if DMARD'S aren't being successful in terms of the managing the disease activity, then you need to go on to the biologics. They are a little bit more stronger drugs. So the way basically translate into my clinical practice is that when I see patients on TNF inhibitors or anti-CD20, anti-IL-6, I know that their disease activity is high, and these drugs are trying to bring that down. So their immune system is going to be a little bit more under pressure. So if they are presenting with a wound, or if they have if you have cuts or anything like that, I need to basically keep a closer eye on that until that heals. The other thing which basically these things highlight is that if a patient is coming in with second MTPJ pain, and they're on biologics and the disease activity is quite high, then you're not treating that second MTPJ just as pain in second MTPJ as an MSK would. You have to consider the disease activity. You might have to, in the NHS, we were really fortunate that I could have a look at their history of medication when it was reviewed, when they were seen by the nurse, when they were seen by a rheumatologist, and when was the last time they had their blood test taken. All this gives me an understanding and give me an information that, do I need to manage that second MTPJ myself, or do I need to get a rheumatologist basically on board? And we were quite lucky that I could just quickly run out and say to them that I've got Mrs. Smith sitting in my thingy. She's explaining that she's got pain in second MTPJ, but I think there is disease activity is increased, and she'll probably benefit from having a bit more of a review on her medication, and they will do that. So you're not managing the condition on your own, and that increases your outcomes. That basically improves your outcomes. So you're not just looking at it, pain in the second MTPJ, because if the disease activity is not controlled, the pain, whatever you do to the second MTPJ, that might not improve at all. Any comments? Anywhere where you've kind of
I'm actually learning more than anything else. Go on, carry on. This is something that I'm not familiar with.
So that's one of the key things that you got to keep an eye on is that we as clinical practice in private practice, we don't have access to these numbers, we don't have access to these results. But what shouldn't stop us when you are seeing a patient who is coming into your clinic for pain, musculoskeletal pain related thing, what you can do is that you can look at their medication. That can give you some indication how their condition is managed. Partly that you can send a letter to their rheumatologist. They'll be more than happy to kind of work with you and inform you about the results. You can speak to the GP. You can get these results on hand to be able to look into a little bit more in depth. Yep.
Okay. Yeah.
Okay. So DAS28 is a tool to calculate DAS28. They generally tend to do that in the clinical setting, where what they're looking at the inflammation in the joints, how many joints which are involved. Funnily enough, it doesn't include feet at all. I think I know why, because we've got lots of joints in our feet, and if they sit there, start counting joints in the feet, they'll have like a humongous list of the joints that they need to consider. So, but feet aren't involved. They count the number of joints, swollen joints, count the number of tender joints out of 28. Take blood to measure their ESR and CRP, and ask you as a patient to make a global assessment of your health, indicated by marking a 10 centimeter line between very good and very bad, and from there they measure your disease activity. So if the disease activity is greater than 5.1, that is high disease activity. If it's lower than 3.2, that is low disease activity. And if it's less than 2.6, the patient is in remission. I think it would have been a very lengthy presentation if I would have kind of gone into each condition in a bit more detail. So what I've done is that kind of put them all together in a way, and we can perhaps look at these in a bit more detail later on some other time. So a lot of the complications associated with RA in terms of the forefoot, yeah, painful joints, tender and swollen MTPJs. Feet are the first thing which get affected with RA, and a lot of the time you generally tend to see the deformities in the lesser toes. Daylight sign, you know daylight sign, Abid?
I've forgotten it.
Okay, so when a patient stands, they have like a gap between the toes. So that's
Star Trek, yeah. I remember that.
Daylight sign, splayed forefoot, so the forefoot basically splays because of the deformities. Lesser toe deformities, hammering of the toes, closed toes, that's always there. HAV is a bunion, it's a secondary to RA. So lots of my patients who have rheumatoid arthritis present with bunions basically. Plantar fat pad displacement. So because of the joints being affected and there's closing of the deformities, as the toes tend to basically close, the fat pad displaces, and hence why it becomes a little bit more. A lot of the times I hear from patients that they say, "Oh, I feel like I'm walking on pebbles," and that is because their fat pad displaces, and they are literally walking on their joints, which are probably tender and swollen anyway. So it is painful for them to kind of stand and walk on that. Any forefoot complications that you've come across with the RA?
Bunions, plantar fat displacement, and heel pain are the three things that I would see quite a bit of. Painful joints, yeah, I've injected the first MTPJ with like steroid on more than one occasion for somebody who's got RA and a very painful joint. In fact, I've injected it with hyaluronic acid as well. But yeah, it's generally in the feet, it tends to be the first MTPJ, sometimes heel pain. Bunions, a lot of them have. I think it's those ones that were diagnosed back in the day. Yeah,
so the patient, as I said, that as the drug management improved and the condition is managed more aggressively to start off with, the deformities are less and less.
That's right, yes. Yeah, apart from that, yes, I agree.
Here's some pictures of some bunions, lesser toe deformities, closing of the toes, overriding, and all that going on, which is a very common sight for, again, patients who were diagnosed several decades back, and it's much improved now. REARFOOT, tenosynovitis, tibialis posterior tendon dysfunction is one of my main bugbear when it comes to patient with RA. It's one of the biggest tendon, and it's got a sheet which gets affected quite a bit. Their medial longitudinal arch drops because of that, because that is the biggest tendon which stabilize the arch and help us actually walk. It's a condition which I think I'm quite passionate about. I've done a couple of my excuse me. I've done a couple of my assignments on this, and I quite enjoy that tibialis posterior tendon dysfunction. And because I saw it so many times, and it's not easy to manage, especially for the patients who have the RA, because it's difficult to rehab, it's difficult to strengthen because of their other issues going on. Footwear-wise, orthotics-wise, they can be quite difficult to accommodate, and ladies especially don't want to make footwear which can basically accommodate something a bit more substantial in terms of the orthotic. So it's a condition which I had a massive problem with, but I quite enjoy it. You talked about the heel pain a lot of the time, retrocalcaneus bursitis and plantar calc bursa as well can get inflamed if they have disease, increased disease activity. So yeah, a lot of the time when you get patients with the bursa sort of pain, you need to kind of start questioning the fact that how their disease is being managed. Anything you'd like to add? Reduced MLA is the dropped arch. There you go. Tibialis posterior tendon dysfunction. So I don't know whether it's acquired adult flat foot deformity. Is very common with patients with RA, adult acquired. It's one of the other AAFFD basically. Where what happens is that over the period of time, the arch flattens out and out and out and out and out, and I have seen literally patients walking on their medial malleolus. I have literally seen patients. I wish they would have allowed me. I did request and ask, but they wouldn't allow me to take the picture. They were that bad that their plantar aspect of their feet were facing away when they were standing. They had very little mobility. We were doing home visits, and that was in Dewsbury. The extent of the condition is that, as it basically says, it's a progressive condition, and it just slowly goes and goes and goes and goes. So I was quite proactive in terms of managing this in more of a younger patient. So I was encouraging the rheumatology department to set up a pathway so that when patients get diagnosed early on, rather than us waiting for them to be developing an issue and then coming to see us, we were trying to develop an educational program for them so that a patient comes in, get diagnosed, for example, at the age of 35 or 45, a lady gets diagnosed, then they can come and see us and we can educate them about their footwear, how to manage their feet. Again, if I feel that they need assistance with the orthotics and activity modification, the exercises, so we kind of devised a little program for them as a preventative measure for a long term. Unfortunately, I left the department fairly quickly, so we didn't have the ability to kind of audit that and look at it in a bit more of a long term. And I'd be quite interested to know if something like this could be run over the period of several years to see whether that can actually work as a preventative, if not preventative, it's more of a management to prevent musculoskeletal injuries of the feet associated with RA. Am I waffling on?
I'm just listening. Carry on.
If I am waffling on, do tell me. GAIT, again, in terms of their GAIT, it changes. Of course, with all the deformities or the condition, the pain, loss of function in the joints, reduced quality of function, mobility in the joints. So what I often tend to see patients who suffer with that have reduced gait velocity, so the speed is slower, and increased double stance support. So what that means is that as they have increased double stance support when they are walking, they have increased pressure time integral on their feet. So if they have a deformity, for example, on first MTPJ, and they are, if you put them on a pressure plate or a scan, they have increased pressure on first MTPJ. then when they are walking slowly and they have increased double stance support, that means that they're loading that for a longer period of time. Now, the way this is significant is that this could cause pain and discomfort, and in more extreme cases, this could be this could mean that they can actually end up developing a wound there because of the increased pressure there. So when we are doing the GAIT, when we're doing their GAIT analysis, these things need to be kept in mind. So when you devise if the pressure goes above a certain number, I can't recall that number at the moment, I'll have to dig up my paper, then they have increased risk of developing a wound. That is, the paper is predominantly done in more diabetic patients, but I felt that it's quite relevant to the patients with rheumatoid arthritis as well. So then, as a preventative, you need to manage that load, whether that is a first MTPJ cutout, using a yellow poron to basically alleviate some of that pressure, or putting a PMP pad on to redistribute the pressure. So you just need to figure out a way of redistributing the pressure and reducing the pressure from a smaller area. Reduced MLA peak eversion of the rear foot on weight bearing. Again, as we talked about the posterior tendon dysfunction, and their arch tend to develop, to collapse with the time. So the peak eversion on weight bearing is reduced. Decreased lesser toe contact area, increased peak forefoot and midfoot pressure area. So because the lesser toe deformities and the toes start to basically clump, they don't get in contact with the ground much, and a lot of the forces tend to be on the midfoot and the forefoot when they're walking. Anything you'd like to add? No. Treatment. Treatment-wise, it's a very holistic approach. Like anything that we do, we need to basically take everything into account. We need to take in account their patient's medical history, their medication, their beliefs, their approach to it, their mindset to it. Apparently, my mindset needs to improve according to Abid, and I'm working on it.
Yeah, that's good.
I'm working on it. Education-wise, there are two really good free educational sources patients can actually go and access. NRAS is a website, and it's a charitable run organization who are doing great work with regards to inflammatory arthritis, and there is tons and tons and tons of information, not just for the patients, for the clinicians as well. And Arthritis Research UK is the second one. They are my Bible's go-to places every time that I need to get a bit more information, whether that is printing a leaflet, emailing a leaflet to the patient. You can just get PDFs. It's again, it's not just for the patients, even for the clinician. You can actually register there as a professional. There you can have newsletters and all the updated news associated with it. And education is a very, very big part of the treatment. Again, skin pathologies. Often I've seen patients with callosities because of their deformities. They end up putting more pressure on certain areas. They develop more calluses and corns, and that can lead to the ulcer. So one of my, as a clinical lead, my big portion of my work was ulcer management, callus debridement, and that goes hand in hand with the orthosis. So we looking at predominantly accommodative orthotics. So pretty much all of my patients who had rheumatoid arthritis and had deformities had some sort of an orthotic in their footwear, because I feel that you just cannot manage their discomfort and cannot manage their condition, even if that's callous, without the help of an orthotic. Footwear was a very interesting one, and it's an integral part of the management from a podiatry point of view, not so much from the patient point of view. I had some amazing patients who were really happy with the bespoke footwear, but then I had so many patients who just do not want to have the bespoke footwear. They feel like that they're kind of giving in. They feel like that they still want to present themselves, and because it affects ladies more than men didn't have a lot of issue with, but the ladies, of course, they want to wear still pretty shoes, and I don't blame them personally. I always used to have, this is a tip from me, Abid, is that when you're having these discussions with the patients with regards to the footwear, and don't be authoritative, and say that this is what you need, this is what you can get, and you have to do it, or say that I'm offering it to you, take it or leave it, it's your choice. Rather than that, I always used to have a little trade-off, a little discussion, and we used to come up to sort of an agreement. And the way I tend to do it is that if a patient does not have any deformities, then I would encourage them to go and buy a decent shoe from Clark's or from any good shoe shop. If they have a mild deformity, then I would encourage them to consider wider feet catalogue. I can do the measurements for them, and we can send it off. The wider foot catalogue and Cozy Feet have got a footwear which are, for example, you don't need to, a lot of the time, what do we do if the shoe is a bit too tight? We go a size bigger. They have the same sizes, the right sizes for you, but in much more depth and width, and they're variable as well because they come in several layers of poron, so you can make a same shoe as a 4 variable 4E, and you can take 2 layers of 3 mil poron out, and that becomes a 6E basically. So the depth can actually increase there, and they do a pretty good job of with the footwear. They look presentable enough, and that would be my second offer to them. And the third offer would be is that I would encourage them to have a bespoke of footwear with an orthotic. And the way I encourage them, this is something which worked for me quite well actually, because the way I have this discussion with them, I said that how much time do you spend at home? So patients who have these sort of chronic conditions tend to spend a lot of their time at home, don't they? Yeah. So what if we have a bespoke shoe or a house slipper with an orthotic for your house, and you wear that most of the time that you are at home, and then when you want to go out, you can wear whatever you like. Bearing in mind that of course it fits, of course it's not causing you too much pain, and of course if you are not doing like several hours of walking or anything like that, but they can have their little glory time when they're going out. They don't have to worry about it, and by that what we actually can achieve is that they're wearing the good footwear, the good support for most of the time when their feet are in contact with the ground, and then they have a little glory as well.
Okay.
What do you think?
I agree. Yes, that's a very good strategy.
It worked really well for me. It worked really well for me. We managed to convert so many patients who initially just opposed the idea of having a bespoke shoe. And I must say, I should have had some pictures of some bespoke shoes. I don't know in private practice whether we see enough of the bespoke shoes coming through the door. They are, when they are made for you as a therapy, and you've got deformities, they're made around your foot, so they don't look grey. They're there to accommodate your foot, not to. Although I must say that things have improved immensely, and they can do a really good job of making them look as best as they can, but are still, they're not the best looking shoes. I don't want to discourage anybody, but yeah,
Okay.
you know what I mean.
Okay.
So insole therapy, custom orthotics, yeah, we used to use custom orthotics quite a bit to reduce foot pain and deformity, to reduce rate of deformity progression. That's a questionable thing, and it's something which we cannot measure, and there is some hint of this in some research papers, but again, it's not a very well researched, so I don't know whether we can actually make these claims or not, but I used to use custom orthotics on a regular basis for patients, foot pain and deformity accommodation anyway. Accommodative cushioning and offloading, decrease plantar forces, increase joint area, redistribute pressure. So accommodative footwear, accommodative orthotics are, like I said, most of my patients, if they have any issues with their feet, or if they are coming to me on a regular basis, whether that's callosities, whether that is a functional issue, they have an orthotic. Most research is based on custom orthotics with focus toward functional devices, early phase of the disease, and accommodative devices with long standing disease. So in early phase of the disease, more functional sort of orthotics are used a lot more as compared to the later on, because later on most functional devices they're not very well accommodated by patients. Patients find them too hard, patients find them too uncomfortable. One of my, do you use the triple density EVA, where you can actually have a device made for a patient where you can have a REARFOOT as the high density EVA, midfoot and medium density EVA, and forefoot as low density EVA?
I don't see this demographic of patient. So most of my orthotics that I prescribe are for tend to be for sports injuries and so on and so forth. So I have in the past prescribed for a diabetic ulceration, which I did use EVA, but not necessarily different densities.
Yeah, so it's a Langer, and most of these labs now have multi EVA, a block of multi EVA sheet where they can make an orthotic rather than using a low density underneath and the high density on the top and covering it like that. They can use medium to low density is very, very well accommodated, and if you cover it with poron, yellow poron, again, that increases the accommodatability of the device. Patients tend to like it a little bit more. I used to do quite well with that, with them too, because then I can achieve functional control for the REARFOOT, and then more cushioning and accommodation. Are we running? Is this going on?
10 minutes before my patient, so okay, feel free.
About 10 minutes.
Yes, you got 10 minutes.
Okay, so let's speed this up. So limited evidence for prefabricated orthotics in RA, but yeah. When I talk about the pressure analysis, so F-scan InShoe build system is quite a good one to it helps you to identify where the pressures are, and when you're designing an orthotic, and you can test the orthotics afterward as well with it to see whether if you're trying to take the pressure off, for example, from first MTPJ, and we can measure what that pressure is in kilopascals, and you can
do that with the footwear on. This is not an InShoe pressure analysis, is it?
This is InShoe. This picture isn't of InShoe, but InShoe F-scan is an InShoe pressure analysis system, which can be used pre and post. So
you get them to walk with the insoles and the shoes on over the gait plate.
Yeah. not the GAIT scan. So it's an in-shoe system. So you have the cutout of the sensors in the shoe.
That's pretty cool. That's pretty,
Yeah.
So that is an in-shoe pressure analysis. Yeah, that is pretty cool.
Yeah. So again, efficacy of offloading devices can improve. So we know what we're doing. If we basically offloading from first MTPJ, are we basically increasing the pressure somewhere else? It's quite cool to basically measure that. Again, limited research. Research suggests that scan is unreliable in accurate pressure mapping, but I think we never use these skills as standalone anyway. As a clinician, I would make sure that I have all the other bits covered before I do things like these. So it's not based on just the F-scan reading to what I'm going to devise and design for them. SPAs, group of inflammatory arthritis is, again, etiology is unknown. Bacterial DNA and protein often found in the affected joints. Possible bacterial trigger immune infection. That's what the SPAs are. Psoriatic arthritis is the second one, most common. After the rheumatoid arthritis is what I've seen in the clinical environment. Clinical feature, again, similar to the RA, joint stiffness, swelling, dactylitis and enthesitis, and pitting onycholysis of the nail. So I'd like to go into a little bit more detail about enthesitis. Is that when patients have enthesopathies, so when patients come to...
First define to everybody what an enthesitis is.
So enthesopathies, so when we have like the insertion of Achilles, for example, let's talk about the Achilles, into the calc, if the enthesopathies, when you have like insertional Achilles tendinopathy, enthesopathies arising from that. And part of that, I'll let you actually describe enthesitis. I don't think I've done a justice to that.
As with anything that ends with itis, it's an inflammation. So it's an inflammation of any structure. So that can be the plantar fascia. Some podiatrists have called plantar fasciopathy basically enthesitis. It could be any structure that is inflamed at the insertion. It could be the Achilles or anything else. It is something we see a lot of in inflammatory arthritis. But yes.
The point I wanted to make with regards to the enthesopathies is that one thing which you got to keep an eye on is that if a patient is getting an enthesopathy and you're managing them as an MSK condition, keep an eye on how their psoriatic arthritis is doing, because by doing the drug management, that can settle down as well.
Yeah, absolutely. It's the same with gout.
Dactylitis, sausage toe. Have you seen any?
Unfortunately, yes. I'll try and run away from them, but yes.
Well, if you see that, that's screaming out psoriatic arthritis. Enthesopathy, as you demonstrated, that it's basically where the insertion of the Achilles into the bone, and they get inflamed. And they light up like anything under the imaging. Again, investigations rely on clinical examination, ESR, blood count, CRP, negative RA factor, radiological investigations in terms of erosion with proliferation of the adjacent bones, periostitis, and new bone formation is what basically they look at before they're saying that you have psoriatic arthritis. Again, management, exercise, NSAIDs, DMARD'S, again, has a limited evidence, but they have started to do that more and more with improved results, and they're looking at it in a bit more detail. BIOLOGICS currently has got is a currently area of research. This is the last slide. So when you're managing rheumatoid arthritis or inflammatory arthritis, it's not just you as one clinician dealing with all that. Make sure that you look at a patient in a very holistic manner. And there is, again, in the National Health, you have a really good MDT team, and which is a very vital to managing patients with rheumatoid arthritis, and that consists of rheumatology consultants, rheumatology nurses and specialists. I work very closely with these two group of clinicians. I had the privilege to basically run into their room and just call them in, and they very kindly pop in, and it's their patient that we're managing as well, so we work as very closely. Orthotists, I think in lots of the podiatry departments, they need to have a bit more of a joint clinical session. At Bucks, we had a clinical session with an orthotist and a podiatrist present together, looking at footwear and orthotic development from both points of view. Have you got to go?
Okay.
And the way that basically lifted patient care is that the understanding that we have with regards to the ulcer management and the pressure redistribution, which can be translated into the prescription of the footwear and orthotic, and then orthotists coming from their point of view produce much better outcomes once we work very closely. Physiotherapy, again, is a key element with all these inflammatory conditions. Exercise is the key, movement is medicine, so you just got to keep moving, so they play a key role. GPs, again, they need to be in the loop for all this, as patients are often going to the GP practices to get the bloods and all that sort of thing taken. And then there is podiatrists, and that's us, and that's what we do.
Brilliant.
Okay.
You don't have any more slides?
Pardon?
Are you sure you don't have any more slides?
The next slide is.
I was waiting for you to talk about gout.
I think I've had a couple of presentations, and the one which we managed to open doesn't have a gout section in it, unfortunately. But again, we can talk about that in another.
I see. I mean, briefly before my patient comes, which is a couple of minutes from now, I see a lot of gout, and when you ultrasound it and when you view it and you feel it, it's obvious that it's gout. So I do manage that quite a bit. But thank you very much, Asif. That was a massive learning experience for me. I learned a lot by listening to you, and it's an obvious that you have a huge amount of expertise in this particular pathology, well, in these pathologies, in like
sorry, I feel like I haven't been able to do the justice to the presentation, but I should have had some more images, but I had so much issue trying to come up with this presentation and open on this system and do that. It didn't work out as I hoped.
Okay, but thank you very much. Our next one is going to be on Achilles tendinopathy, which is interesting. And that should be shortly. Is there anything else that you wish to add, Tosif?
No, it was quite a good talk. So I hope people learn from it, or if anybody does have any questions, or if there's anything which we can improve on, please let us know on the comment below.
Thank you very much.
Thank you.